How's everybody doing? Dr. Gillard here. It is week 7. It is Wednesday, and it's time for CVPP lab examination, and this is the lab examination lecture. And yeah, important today, auscultation of the heart. You got to know this for boards for sure. So let's go through it. So here's an older, you should go to this YouTube. It's on my channel. There's the link. I don't know how to make that live to you guys, but you have to go to my channel. Gillard Anatomy will pull up my channel and go find that, because I do expect you to know how to do this. I might try to get have my wife do one today. We'll see how she's amenable to that or not. But if not, we have a really nice one right here with my grandson, so you can see no chest, or no chest, or you can see he has no shirt on, so you can see it a little bit better. All right, informed consent, and these PowerPoint slides, this is I just made them, finished them this morning. They were in the old doc format, so I converted them to PowerPoint, so there might be a few errors here and there, so sorry for that. Informed consent and a warning. Obviously, you want to tell your patient, "Dear Mrs. Jones, I'm about to do an examination of your heart. Is that okay?" Yeah, that's informed consent. And then give them a little warning. "Mrs. Jones, I might be, as I auscultate and listen to your heartbeat, I might be stopping for a really long time in certain spots just to check things out. And that doesn't mean there's anything wrong with you. People get nervous sometimes when I do that, so I don't want you to get nervous. If they get nervous, of course, that turns on sympathetics, increases heart rate, and you might lose some murmurs when the heart rate speeds up, so you don't want that. Why would you auscultate the heart anyway? You're going to be listening for, I like this, I'd almost guarantee you. I didn't have time to put a lot of stars on this slide, but this is a good slide. You're listening really for changes in blood flow through the heart, which make weird noises. What causes these changes in blood flow? Well, it could be structural abnormalities of the heart. It could be myocardial abnormalities, like a stiff left ventricle from left ventricular hypertrophy. It could be changes in viscosity of the blood from anemia. It could be changes in the pericardium. Pericarditis can cause different types of murmurs, a friction rub, for example. All right, so these changes in the structure of the heart, or valve abnormalities, or holes in the heart, that's a structural change. They can all cause murmurs, and that's what a murmur is. Any change from the normal lub-dub, lub-dub, lub-dub. Now, the exception of that is I could have added in here the S3 heart sound. As long as the patient is less than 40 years of age, especially kids, they might have a third heart sound, a ventricular gallop. And that might be completely normal, and most grow out of that by the time they hit 40. So aside for S1 and S2 and maybe an S3, there should be no other noises, just a lub-dub, or maybe the S3 heart sound, which is supposed to sound like long, short, lub-dub, 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 lub-dub. That's an S3. We'll get to that, though. What could murmurs be caused from? I kind of said this. Valvular disease, stenosis, regurgitation of the valve. There's a snap sometimes with, instead of lub-dub, 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 lub-snap-dub, 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 lub-snap-dub. So there's when a valve opens or gets sticky, it can snap on its way open, or it can snap on its way shut. We're not going to get into these. I do have a YouTube video that goes much deeper into these heart sounds, but has not that much traffic, so I'm not sure how useful that is on boards. I don't think they probably go too deep into this on boards. other than what I'm covering here, of course. So valvular disease, heart muscle diseases like left ventricular hypertrophy, that can create an S4 heart sound, amongst other things. Pericarditis can create friction rubs. It sounds like sandpaper when you listen to the heart. Anemia, kind of said all those things. The stethoscope, we're going to be using the diaphragm for the general exam. And if you're asked to do some special parts of the exam, you need to flip it over to the bell. If you want to listen for S3 and S4 heart sounds, I think that's better. I should probably make a note to fix that. I think it's better to say heart sounds there. Heart sounds on, this is slide 6. The S4 though it's a sound, heart sound as well, and that's pathological, so it could be considered a murmur. But and then so another key with when you're using the diaphragm, remember you can press the diaphragm down very firmly. Don't put your finger, because the bell will be deactivated, but don't put your finger on the bell anyway, just in case you have a crummy stethoscope. You might hear your pulse through there. Nowadays the stethoscopes are not going to let that happen anyway. But you might have an old school examiner, and so you don't want to do that. It's just a bad habit. Now for the bell, you have to be careful. You want to push down very lightly with the bell on the skin. If you push down really hard, it stretches the skin, and then it acts just like a diaphragm, so you might as well be using the diaphragm. So the bell has to be pushed down delicately. Doctor-patient positioning. So the patient will be supine through most of this examination. There are some special maneuvers. There's the left lateral decubitus position. We might roll them on their left side a little bit and then listen for the S3 and S4 heart sound with the bell. Actually is the one we use that for. If you really want to get technical, there's a right lateral decubitus position that you can also listen for problems with the right ventricle and right tricuspid valve. We're not going to get that deep. We're just worried about the more dangerous murmurs in the left side of the heart. Then there's the sit-up. Let me fix that. Slide 7 should be sit-up, not set up. So you want to sit the patient up. I have more slides on this. Sit up, bend forward position. Good for listening to the semilunar valves. And then the doctor, as always, will stand on the right side. Bates actually goes against the grain. Bates goes against Jarvis, and Seidlin says that you can stand on the left side. So technically, Bates is the oldest board book for chiropractors, so technically you could stand on the left side. What are we examining? We're examining a region called the precordium, and that's the anterior chest, right? No, I don't think I'm going to draw that. I'll show you in a minute. Specifically, we are going to be examining the 5 cardiac areas, or auscultation areas, or auscultation zones, or valvular areas. So we're going to be examining these auscultation areas of the heart. A little different from the pattern we learned last week, because you're not going to look at up in the jugular notch. You're not going to look up there, and you're not going to look down at the apex. Right, so here are the auscultation areas. You have to memorize these. All pigs eat too much, right? Aortic. So I'm going to go over them on this slide, but I assume you know these from first quarter. There's the aortic area, pulmonic area. There's Erb's point, tricuspid, all pigs eat too much, and mitral area. So the aortic area is you have to learn how to say where they are. It's the second intercostal space, right parasternal border. You've got to learn that. Where's the pulmonic valve? Well, it's in the pulmonic area. That's in the left second intercostal space, parasternal border. Where's Erb's point? Most texts say it's in the third intercostal space, left parasternal border. Where's the tricuspid area? The tricuspid valve is auscultated at the fifth intercostal space, left parasternal border. Where's the important mitral area? What's an AK for the mitral area? What else can you find there? Apex of the heart is there. That's where the apical impulse, we taught you last week how important that apical impulse should never be bigger than a quarter. Shouldn't be bigger than 2.5 centimeters. Right? Basically one finger pad, one intercostal space. If it's bigger than that, the patient has a decent chance of having left ventricular hypertrophy, which is, that'll kill you. It'll wreck your heart. Right? So that's the important mitral area. Where's that one? Well, that's fifth intercostal space in the midclavicular line. Technically, it's just a hair inside the midclavicular line. Why is it called the midclavicular line? Because it's in the midclavicular. It splits the middle of the clavicle. Now, these are the traditional ones. These are good enough. In reality, with electronic stethoscopes, they've found that some, like aortic stenosis, doesn't always show up right here. It actually can show up sometimes all the way up into these regions. Right? But we're certainly not going to take the time to auscultate all of these things. We can use an inching technique. I'm going to show you an inching technique where we will hit that deadly aortic stenosis. That's not a good thing to have. So we'll auscultate sort of in this Z-type pattern so we don't miss any. Each one of these circles is going to be auscultation. You're just going to inch your way through the auscultation zones, and it creates a Z pattern, as we'll see. Okay? But the point of this slide was that, and there's 2 points of this slide. The other, let's go back to the old traditional one. Notice that this is where you have the highest chance to hear murmurs of the aortic valve, stenosis, either stenosis or regurgitation. But if you do surgery, that's not where you find it. It's not even over the heart. The actual valve itself is right here in the third intercostal space, kind of right in the center of the sternum. See how that works? Look at the mitral valve. Mitral valve is really here, way up here in the close to Erb's point, yet it refers sound to the mitral valve region. See how that works? So these auscultation zones have been scientifically calculated to give you the best chance at finding a murmur with these different valves. Got it? All right. All pigs eat too much. That's the best one. A pet monkey is another one that is used. All pigs eat too much probably works better. So A, again, I went over these. Aortic area, pulmonic area for P, Erb's point. And what is the aortic area? That's where the aortic valve lives. What's the pulmonic area? That's where the pulmonic valve sounds are best heard. Erb's point is interesting. I do like Erb's point. Erb's point is a really good perch. If you only have time to listen, and I'm not saying to do this, if you examine the heart, you're responsible for it. So you better inch your way along the entire Z pattern. If you miss something, you're liable. But if you've ever had a sports physical back in the day, they don't, or even if you've ever went to your primary doc, they don't go do the whole Z pattern. I mean, I have cardiologists. No one ever does that. I mean, they order tests, right? They can order an ultrasound, and they do a stress test, and they can do a CT. They can do all sorts of things. But you should really do the entire Z pattern. Erb's point is interesting, though. If you're going to just get lazy and do one spot, that third intercostal space left peristernal border is the way to go. That's sometimes called the AKA as a second pulmonic area, because it's also really good to hear. Let's go back and look at. Here it is. It's a really good perch. You can actually hear, because the aortic closes so much louder than the pulmonic, when you perch your stethoscope here, you can hear both of these valves equally well. Because the pulmonic is so much quieter, you need to be closer to it. This one's so much louder, you need to be further away from it. So it's a really good perch to listen to both of these valves and assess things like splitting. We'll talk about physiological and fixed splitting here in a minute. but it's a really good perch. And you can hear the mitral valve halfway decent as well. Okay, the tricuspid area is where the tricuspid valve is. Mitral is where the mitral valve. And that's also where the S3 and S4 heart sounds are heard, in addition to mitral regurgitation or mitral stenosis is also heard there. All right, there's the classic Z pattern. We talked about that. Make sure you know which way to go. Which way do you go through this thing when you auscultate? You can do it either way. Traditionally, you go this direction. Start at the aortic and work your way down. And when I ask you to auscultate the heart, we're going to teach you a hopping pattern. But I want it's probably easier to go this way because all pigs eat too much. Some of the books recommend going backwards because the flow of blood actually goes better like that. I think either way is fine. Which direction? I just said that. Bates and Jarvis recommend starting. Bates is the oldest book. Jarvis the school likes this book, but it's not a board book. So all these books have their faults. Bates I do like. That's my favorite of the books. That's probably why it is but Seattle's a board book as well. Put all three together and you can get a pretty good story. That's what I've done. But Bates and Jarvis recommend starting from the apex, so the monkey, and working backwards through the Z pattern. Seattle says you can go either direction. So kind of talked about inching. So Bates and Seattle recommend an inching pattern. So that is the way to go. You don't want to miss murmurs, especially with the aortic valve. You want to go across the sternum. You should listen to each area at least. Put the stethoscope down and listen. 1001, 1002, 1003. Have the patient breathe normally. Now, Seattle goes a little too far, I think. Seattle wants you to inch, and he wants you to have the patient hold the breath at every spot. I think the patient would be probably lightheaded if you did that. So I think it's just fine as long as they're not panting, breathing quietly with their mouth closed. You should be fine. But you should spend at least 3 long seconds at each auscultation spot. Now, when you're going to get tested, for me, and you can ask them if you get asked to do this on a board, you can ask them, do you want me to use the inching technique or the hopping technique? I think they will appreciate you using the hopping technique because they're doing a lot of these examinations and they don't want to. It takes a long time to inch your way through the Z pattern, 3 seconds at each spot. So if you hop just to the auscultation areas, I think that's probably the best way to do it. In real practice, though, if you really want to listen, you should inch your way along. And I redrew a picture of that. Let me just go back to hopping. Where's that nice picture? So if you're going to hop, I already messed this up, didn't I? If you're going to hop, let me turn this on. Let's see. What color do we have? That's fine. So if you're going to hop, you're going to listen here, 1000, put the stethoscope here. Notice how far this is away from the clavicle. In reality, it's about 1 diaphragm length away. The diaphragm of your stethoscope better not be touching your clavicle. It better be further away, or you're going to get points off for that, as I say in the video. So you're going to listen here, 1001, 1002, and you're going to talk to me as you do this. Okay, let's start with the aortic area. I'm listening here. And in your head count 1000, 1002. Okay, now I'm going to jump over because we're going to do a hopping technique to save time. I'm going to jump over to the pulmonic area, and then you're going to be quiet. All right, now I'm going to jump down here. You're placing your stethoscope here. Now I'm at Erb's point, and you can tell me these points as you go through. Okay, now I'm coming down to here. I'm going to do the tricuspid valve. Okay, finally I'm going to go in the midclavicular line. If it's a female, make sure she covers her breast tissue. There's a hand. This is why I don't draw again. And have her pull it toward her left shoulder. And that little wire of the bra usually is right there. as I told you last week with apical impulse. So she's in the mid. So I'm gonna now. Let's role play again. Okay, now I'm gonna go in the mid-clavicular line, and she's gonna. Could you move your breast tissue, please? I'm gonna place the stethoscope, the diaphragm, right here in the mid-clavicular line, and then you can listen for 3 more seconds. Got it? Okay, we talked about inching, we talked about hopping. So you will use the diaphragm to go through these zones. You should, when you start the exam, you should put your earpieces in your ears correctly, and then tap with your finger. Let the examiner see you tapping the diaphragm, so he or she knows that you're smart enough to make sure it's engaged. Right? Many stethoscopes, you twist the end piece to engage either the diaphragm or the bell. And so this way they will know that you're not faking it and you actually do have the diaphragm engaged. And then you go through the auscultation areas that we just talked. Remember to listen to 3. You're going to hop and you're going to listen 1001, 1002, 1003. I guess I got to fix that, right? 1002, 16. Okay, so here's that video with my grandson. We started here. I'm right in the middle of moving it, but I started at the aortic. I went to the pulmonic. I went to Erb's point. Big jump. I went all the way down from Erb's point down to the tricuspid area, and then jumped over to the mitral area. That's how you auscultate via hopping style. What are we listening? After you're done auscultating, I'll say, okay, what were you listening for? Tell me at each spot what you listen for. So we listen for the heart rate. Heart shouldn't be going. You can use your watch if you want, but you can get an idea. You know what 100 beats is. If the heart's flying, that's not a good thing. The heart should be normally between 60 and 100 beats per minute. Anything over 100, at or over 100 is tachycardia. Anything under 60, I know that's a weird thing because a lot of people have resting heart rates under 60, but that's considered bradycardia. There should be, so the rate you note, the rhythm should be lub-dub, lub-dub. And in your mind, usually in class right now, I stop. I won't do it here to save time, but I say, okay, everybody get out your stethoscopes and let's go to Erb's point, good observation deck, and let's put your mind's eye for the lub. And what is the lub anyway? The lub is S1. What is the dub? That's S2. So first, don't try to listen to everything at once. Just listen to lub, 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 lub. Put your mind's eye on the lub. Forget the dub. Lub, lub. And then see if there's any weirdness. Is there a lub snap? Or is there a snap instead of a lub? Or is there a lub, 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 dub, lub, lub, dub, lub, lub, dub, lub, lub, dub, an S4 heart sound. Okay, so listen to that. Then after you're done listening to that, listen to the dub. That's the S2. What is the S1? What makes that sound? I assume you know that. Right? You just had cardiac physiology with Dr. Doe, so I know you know this. Those are the AV valves slamming shut, mainly the mitral valve slamming shut. And what's the S2 sound? Is that systole? That's the start of systole. When diastole occurs, remember the stretch of the ascending aorta shoots blood backwards and it slams the semilunar valve shut. So S2 is the semilunar valves slamming shut. So now put your mind's eye there. Dub, 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 not lub dub, 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 and listen for any weird sounds there. Okay. All right, and so we listen for the rate. Make sure at each spot. You only have to do that one time. For the rest of them, make sure the rhythm. I mean, maybe it's not. Maybe it's a lub dub, lub dub, lub dub dub, lub, lub, lub dub dub dub, lub. Patient may have an arrhythmia. They may have PAX, PACs or PVCs or PJCs. We'll talk all about those different types of arrhythmias. Maybe they have a supraventricular tachycardia. Maybe their heart's flying 160 beats per minute. You got to catch all that stuff. Okay, so listen for the abnormalities. Let's meet the murmurs. So we're going to talk about the big ones: fixed splitting from pathological splitting, extra heart sounds, S3 and S4, and the ejection sounds. I think I actually cut the ejection sounds out for this lecture. Physiological splitting. So this is a normal sound. It occurs when the aortic and pulmonic valve close. So normally you'll hear aortic and pulmonic valve close at the same time, right? And that would be what? The S1 or S2? These semilunar valves closing. That's an S2 sound. So you have two valves, but the amount of blood going through the right heart and the left heart, they close these valves at the same time, so they sound as one closure. However, if you have a really good stethoscope in a quiet room, as the patient, especially if you have the patient breathe a little deeper than normal, sometimes, well, not sometimes, as they breathe deeper, they suck more blood into the right side of the heart. So therefore, you have more blood to process through the right side of the heart. So it's got to go through the tricuspid valve. It's got to go through the pulmonic valve. And that pulmonic valve closing, because of the longer and more volume of blood that you've sucked into your heart, it's going to close after the aortic valve. Another problem is the aortic valve, if you take a deep breath, it doesn't allow blood to leave the lung. So therefore you get an underfilling of the left side of the heart, and you get an overfilling of the right side of the heart. If you have two unequal globs of blood or volumes of blood, it's going to take longer for that blood to get out of the pulmonic valve. So you get a splitting during inspiration. It doesn't take very long for it to get out here because there's not as much blood. That's called the physiological split. So when you're with a cardiac stethoscope in a quiet environment, you might hear just that lub dub lub instead of lub dub, lub dub, lub dub. You might hear lub dub, lub dub, lub dub, lub dub, and that splitting is very close together. Like you can barely make it out, but you should only hear that during inspiration. As the patient breathes out, it should go back to lub dub, lub dub, lub dub, and then as they breathe in, lub dub, lub dub, lub dub, lub dub, lub dub. Okay, so that's a physiological splitting, and that's normal. Got it? All right, everything I just said, blood's held up in the lungs. You underfill the left side of the heart. I mean, specifically the left. Well, if you underfill the left atria, you're going to underfill, after atrial systole occurs, you're going to underfill the left ventricle as well. Right? So everything I just said. Here's a diagram of that lub-de-dub, 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 lub-de-dub. Okay? Now, an S3 heart sound, which we're going to look at here in a second, sounds similar to this. That sounds like a lub-da-dub, lub-da-dub, or long, short, short, long, short, short. But it's not as close together. Physiological split or fixed splitting, which I'll talk about in a second. S3 sound, you can definitely hear. It sounds like a galloping horse. They classically say it sounds like Kentucky, 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 short, short, long, or short, or long, short, short, long, short, short, long, short, short, lub, dub, dub, lub, dub, dub, lub, dub, dub, lub, dub, dub. Not like a splitting, lub, did, lub, did. It's very close together. So got it? So splitting is really hard to tell apart, but an S3 sound, you can tell. It sounds like a galloping horse. Okay, fixed splitting. So what if I said normally that splitting should disappear as they expire or breathe air out? Because now you should have equal amounts of blood coming into the right heart. Fixed splitting means that they always have that lup-de-dup, 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 lup-de-dup. You can always hear that little split, that really close together split of the aortic and pulmonic valve. The semilunar valves are split. So then what are the conditions that would cause too much blood all the time? And this gets worse in someone who always has too much blood in the right side of the heart. It gets way worse when they take a breath. So it gets very exaggerated. So what can you think of any conditions where you get too much blood in the right side of the heart? We just talked about it in class. Atrial septal defects, where they have a left to right shunting of blood all the time. Right, here's our little heart coronal view. There's our junior high drawing of it. If you have a hole right here in the atria, blood is going to flow from left to right all the time, and you're going to have too much blood in the right side of the heart all the time. Therefore, the valves are not going to close the same. You're always going to have a splitting. Okay, so that's a really good sign of an atrial septal defect. Ventricular septal defect, it's not as bad because if you have a blood shooting in the heart here, the volume isn't going to be as high as compared to up here. And there's some other things they don't understand, but VSDs don't, they can present as fixed splitting, but they usually don't. And these are atrial septal defects without Eisenmenger syndrome, right? Because if they have Eisenmenger syndrome, the flow of blood is going to be reversed, pathologically reversed. We talked about that in class. Third and fourth heart sound, Kentucky and Tennessee. So remember ventricular filling, that's a diastolic, that's a ventricular diastolic event. Let me back up. Remember, we know systole and diastole. Systole is when the ventricles contract and shoot blood out of the heart. Diastole occurs when the ventricles take a quick break and they relax and the semilunar valves slam shut because of that recoil. The blood is pushed back into them. But remember, there's also an atrial systole and diastole. So ventricular filling is really a two-step process. There's a passive filling where blood comes because of the pressure that's imparted on the blood by the lungs. So the left ventricle fills up. We'll just say, I'm not sure what the number is. Let's say 85%. But then to top it off, or to put the last amount of blood, to really pack that left ventricle with blood, that has to be forced. And that's where your atrial systole, the atria contract, not the ventricles. The atria contract, and they squeeze that extra blood and top off the ventricles. So this is a two-process event, and I'll tell you right now, S3 heart sounds occur during this passive filling stage. S4 heart sounds occur during this forced filling stage. Okay, so sometimes that ventricular filling can become noisy. Let's look at an S3 heart sound. It might be called an S3 heart sound. It could be just called a third heart sound. If it's pathological, it's often called a ventricular gallop. You don't call it a ventricular gallop if the patient is under 40 years of age. Let me repeat that. Don't call it a ventricular gallop if the patient is under 40, because kids can have this sound all the time and it's no big deal. But by the age of 40, on average, it goes away, and it better go away. If it's there in a 50 or 60-year-old, it's pathological. Then you call it a ventricular gallop, or all these other AKAs. S3 gallop. Ventricular gallop is the most common AKA, but that's pathological. This is a physiological gallop. Some authors differentiate physiological gallop from ventricular. But 40 years of age is the key. Okay, it occurs immediately after the S2 sound. Okay, so that's diastole. In other words, it's early, it's passive filling of the left ventricle. Okay, they're not 100% sure. I hesitate to tell you what actually causes it. The latest research thinks it's from a vibration of the chordae tendineae. Remember, those are the chordae tendineae hold the cusps to the papillary muscle. What papillary muscle is modified trabeculae carni. I won't go into all that stuff. We'd do that in class. But it's a vibration, they think, but they're really not 100% sure. But look at the sound. And the early cardiologists, for whatever reason, and it doesn't sound like this to me at all, but they say it sounds like the word Kentucky. Kentucky. I like long, short, short, long, short, short, lub, dub, dub, lub, dub, dub, just like a galloping horse, lub, dub, dub, 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 if it's going faster. So that's it. So the lub is still caused by S1. The dub is caused by S2 as normal, lub, dub, lub, dub, lub, dub. But now we have an S3, lub, da, dub, lub, da, dub, lub, da, dub. So see, when I say it occurs immediately after the S2 sound. There's the S2 normal sound, so it's an extra heart sound after that. Got it? And it sounds like Kentucky, Kentucky, or long, short, short, long, short, short, long, short, short. There's another kind of a dirty one online. I won't teach that one anymore. I had some complaints. Some students got offended by that, kind of using the, well, you can look it up. There's a famous kind of reggae doc who uses that, but I won't use it. Okay, got it? Where do you find it? Now, if I ask you to check for extra heart sounds, an S3 heart sound or an S4 heart sound, you have to do something. You have to, first of all, flip over to the bell, because this is a lower pitch sound, and then you have to roll the patient on their left shoulder. So this is called the left lateral decubitus position. Got it? Left lateral decubitus position. Have them use the bell and auscultate the mitral area. Right, and that's where you hear lub-da-dub, lub-da-dub, Kentucky, Kentucky, Kentucky. And then they would have an S3 heart sound. What does it mean? As I said, it's normal if you are under 40 years of age, or if you're a kid, it's particularly normal. My daughter had one of these and disappeared she's about 20 years, it disappeared. Okay, it might show up in someone in their third trimester of pregnancy. It can show up, but again, you're probably not going to be 40 and having a baby. So that's another time it can show up. But again, it's not a gallop. It's not a ventricular gallop. It's a physiological S3 heart sound. Got it? You can see those questions coming on the lab final. What does it mean? Now the books are all over the place on this. I looked for my Cleveland Clinic book, my Mayo Clinic book, McGee, Bates, Seidel, Jarvis. They're all over the place on this. So most of them, the most common response, and Bates says this as well, think congestive heart failure. So the heart is failing and it can't pump blood out. Blood is still being pushed in because of the pressure of the blood coming from the lung. So bottom line is you have too much pressure in that left atrium. When atrial systole occurs, the blood's being injected into the heart. If the left ventricle is overstretched, remember, it pushes the blood in much harder. And so that extra force of blood going into the left ventricle is what's thought to cause the pathological S3 heart sound. Okay, what causes it in normal people? Did I differentiate that? What does it mean? Yeah, so it's normal. It's just chordae tendineae, they think, but it's abnormal in people with congestive heart failure. Okay, you can actually get some lab tests on this. We talked about this in endocrinology. The brain natriuretic peptide is highly elevated in patients. There's a high correlation between that and a pathological S3 heart sound. McGee also points out that it's kind of a bad omen for the future. The 5-year survival rates aren't the greatest with people who have this S3 heart sound in their 60 years of age. All right. It could be aortic regurgitation as well, which can anything that increases the pressure within the chambers. But remember, that's only in people who are over 40. Okay, let's go into the 4th heart sound. I'm completely lost track of my time again. I guess I should get a clock one of these days. I hate looking at clocks, though. So this one, always pathological. Always pathological. If you hear this in a kid, it's no good. I mean, if you're a chiropractor and you even hear a S3, you're doing sports physicals and you hear a S3 heart sound, I would still refer them to the cardiologist. Just say, you know what, this is a S3 heart sound. It's almost always normal in kids, but let's send you to a cardiologist just to make sure, right? That's a really smart practice, I think, because that's not our world. Cardiologist listens, that's their whole world, so why not let the expert listen to it as well? This one is always pathological. This is a bad one. Atrial gallop. This one is closer, well, we'll see. Well, I'll show you right here. I'll show you. The S4 heart sound occurs right before the S1 sound. So they call it an atrial gallop or an S4 gallop. Always pathological. So very close to atrial systole. Let's look at the musical tones now. So here's lub dub, lub dub, lub dub, lub dub, lub dub. Now you add a S4 heart sound in, you get lub dub, dub, lub lub, dub, lub lub, dub, lub lub, dub, lub lub, dub. Okay, see the difference? That's an S4 gallop. There's a, or you can say short, short, long, short, short, long. The early cardiologists, for whatever reason, they thought it sounded like Tennessee, 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 Tennessee. Don't ask me. I'm just telling you what they say. Short, short, long, short, short, long. I will, well, I guess I won't this quarter because we're still online classes, but I technically want you to clap this out for me. If we're doing classes in person, I would have you tap this out. Tap out an S4 heart sound. Clap out an S3 heart sound. Got it? Find it exactly the same spot. Mitral auscultation area, left lateral decubitus position. What does it mean? Always pathological. And it means they think the sound is caused by blood injecting into a very stiff ventricle. So these patients almost always have left ventricular hypertrophy, usually from years of untreated or uncontrolled high blood pressure that wrecks the left side of the heart. Okay, so they have hypertrophic cardiomyopathy. All right, now let's talk about one more thing, the sit-up and bend forward position. So if you're asked to assess the base of the heart, or the aortic valve, or the pulmonic valve, or the semilunar valves, you have to have the patient sit up and bend forward and really blow the air out and hold. This pushes the base of the heart. What's the base of the heart? That's the second intercostal space. It pushes it right in to the chest wall, and it increases your ability to hear the aortic and pulmonic valves. It also increases your chance to hear a friction rub caused by peritonitis as well, a pericarditis as well. Okay, so aortic murmurs, both regurgitation, stenosis, pulmonic murmurs, stenosis or regurgitation, friction rubs. So this is a great maneuver for that. So if I ask you to auscultate, usually what I say in class is, so you're doing general auscultation, the patient supine, And then I'll say, you think you heard something funny in that aortic valve. How can you better assess the aortic valve? Then you have to have the patient sit up, bend forward, blow the air out, and hold. Still use the diaphragm. I can make a note of that. For the add diaphragm, you will be using the diaphragm for this assessment. All right, got to run. So I'm going to either go to that YouTube link and look how that exam is done, or maybe I'll get my wife, see how she's feeling today. She's been sick. Makes me think that she doesn't have the classic COVID symptoms, but she's had a migraine for over a week now, kind of nauseated. Yeah, a little bit worried. But anyway, we'll see if she's up to doing one. All right, take care.